Posterior polar always remains googly for everyone.
Good morning, chairpersons, ladies and gentlemen. The title of my paper is Hydissect, a new surgical technique in the management of posterior polar cataract. The authors have no financial interest in the subject matter of this presentation. As you know that posterior polar cataract is a surgical challenge due to its associated high incidence of intraoperative posterior capsular disruption. Routine phacoforces, even any attempt to detach the cataractous plaque from the posterior capsule, may lead to complete pre-extraction disruption of the posterior capsule. Incidence of the PCR has been put 36 to 40% by most of the surgeons. Various techniques have been described to deal with the posterior polar cataract, but most of these techniques, they deal with the type 1 posterior polar cataract. That is a simple posterior polar cataract where you have a posterior capsule which is intact. There is a fragile and weak and brittle posterior capsule, but it is very adjacent to the plaque but not fused with the plaque. So there won't be any defect in the posterior capsule. But these techniques, they do not deal with the type 2 posterior polar cataract, that is complex posterior polar cataract. So what is complex posterior polar cataract is where the posterior capsule is firmly fused with the cataractous plaque. There is a pre-existing capsular defect or hole. There could be a segmental or complete agenesis of the posterior capsule. There could be anomaly extension into the epinuclear complex, and in no way we can prevent the posterior capsular disruption in these cases. So purpose of the study is to describe efficacy of a new surgical approach, that is Hydissect, in the management of complex posterior polar cataract. Secondly, in minimizing the risk of further disruption of the posterior capsule and prevent the posterior segment complications, and also in prevention and pre-extraction of the posterior capsular disruption. We took up 22 cases of posterior polar cataract from our center during 2016 to 2018, and we grouped them into two groups, the simple and complex posterior polar cataract. Complete preoperative evaluation was done in all the cases, including the biomicroscopy, entry-segment OCT, spectral microscopic examination, fundus fluorescent angiography, and posterior segment OCT. All the 10 cases of complex posterior polar cataract underwent the Hydissect, that is a new surgical technique in the management of these cases. So what is Hydissect? Is a bimanual irrigation and aspiration cannula controlled dissection, separation, and extraction of the cortical matter, epinuclear membrane, polar cataractous plaque, and simultaneous posterior capsular rhexis creation. So this is the video which I am going to show you. So you have to do a good inflation of the anterior chamber and do a small video is not playing again. Video is not playing.
Can you play that, sir, separately from the?
I don't know. So generally, actually, this problem comes up. So that is the reason. Look, the laptop should be allowed, I think, because most of the time, most of the cases I've seen presentation, the video is not playing.
Videos had a problem.
You're right. We can use our laptop and present very nicely. So now the problem is coming up here again. This happened many times.
Can you play from there directly?
Even ASCRS, they allow the laptop, but here I don't know. Okay, so this is a video. You have to do a small capsular rhexis of around 5 millimeter, and you should avoid cortical cleaving hydrodissection, but I do small segmental hydrodissection, which the wave should not go into the posterior capsule, and do a good hydrodelineation. Because most of the time the cataract is very soft in these cases, you don't have to much bother for the nucleus emulsification. Nucleus in generally, you can very simply take it out from the capsular bag and rotate, because since you have already done the nuclear delineation also in the beginning itself. The most important point is how to detach the plaque from the posterior capsule. You should not detach, you should not get into the problem of posterior capsular disruption before you extract the capsular component, and this is what I'm trying to do now, using both the irrigation and the aspiration cannula to aspirate the cortex before I'm tackling the central plaque. So central plaque should be left for the last to be removed. And once you have removed the cortex, then you start tackling this plaque. You have to go from the periphery and try to hold with the aspiration cannula and put traction on the center without going into the center first. Slowly and slowly you remove the epinucleus plaque which is attached to the center plaque of the polar cataract, and this is how, but leave the center in the beginning, and then finally you can hold the center plaque and try to put traction and remove this center plaque. So what you have seen now, you can see the posterior capsular defect which has not disrupted further the defect which was already there in the beginning, and finally you remove the remaining amount of the cortex and the epinucleus, fill in the capsular bag, and then put in the IOL into the capsular bag itself. So this was the first post-op picture of this particular patient. You can see the central capsular axis and the posterior capsular axis also. So this video was in short actually, because I haven't shown the full video because of the time constraint during the paper presentation. The last slide I want. So these most of the cases were in the age group of 20 to 40, because this is the time when these cases would present for the clinical symptoms. With the clinical symptom for the surgery they would come, and these are the parameters we recorded, and the results, as you can see here, we could do successful PCC in almost 90% of the cases, and we have been able to put in the bag IOL in 90% of the cases, and the vision recovered almost 20/20 in 60% of the cases, and 20/40 in almost 90% of the cases. So to conclude, bimanual low vacuum controlled aspiration of the cataractous plaque while creating a controlled posterior capsular axis is the most suitable surgical approach in the management of type 2 complex posterior polar cataract to prevent pre-extraction disruption of the posterior capsule and to prevent the possible potential complications of the PCR. Thank you very much.
Thank you, sir. What was the controlled posterior axis? Once that is aspirated, the natural defect is the posterior axis, right? Okay.
See, actually, because the plaque, as well as when there is a adhesion of the plaque to the posterior capsule as well as to the epinucleus, it's very soft. You cannot hold it with the forceps as you do the capsular axis for the anterior capsule. So only way out to hold that plaque and the epinucleus is to hold with the aspiration cannula. This
That's
is the
right.
best.
But the posterior capsular axis that you have mentioned, how you have not done it. It is the natural gap that is left behind, right?
No, that was the traction posterior capsular axis. It won't happen otherwise.
When you are aspirating,
otherwise
you are
there will
trying
be a
to make it
disruption.
a axis.
So I'm trying to put the traction capsular axis, because I'm holding the plaque as well as the edge of the plaque, and then trying to create a capsular axis by putting a traction on it. So that was the idea, so that you don't get into the problem of the complete disruption of the posterior capsule.
My question is that your preoperative assessment of type 1 or type 2, you determine the which technique you will adopt, or you do always a Hydissect in all cases?
100% you have to do the preoperative. That is why I have stressed on the preoperative evaluation. Right. With the OCT is the best way to know that whether the capsular defect is there or not.
I understand. That means when it is type 1, you don't do it.
Type 1 you don't need, because the plaque is already away from the posterior capsule. In type 1 you don't need. It's only the type 2 where the plaque is adhered with the posterior capsule. When there is a complete adhesion, see, whenever you are doing you must have seen the previous video, the posterior plaque was not attached to the posterior capsule. You have a very thin and fragile posterior capsule, but it is not attached, not adhered. It is a type 2 where the plaque is adhered with the capsule. Then you find the problem.
When you are aspirating for the final rexus, does it happen that just part comes out and then you are left with a gap which would anyway will be there, but not really a
Definitely
nice circular
will.
yeah, because that's very fragile.
Very
That
good,
plaque is-
very good point. Actually, what happens, because we used to just hold the plaque and take it out. Then what would happen if you have a previous defect in the posterior capsule, pre-existing defect? You will have a complete disruption of the posterior capsule. The tear will extend to the periphery and you will start having the vitreous and all. But with this technique, you know that there is a defect. So you are very slow, and very slowly you are trying to remove the plaque, putting traction and creating the rexes. I've done almost 20-25 cases by now. This was the presentation which I did in 2018 cases actually. So,
Right. Yeah. Any questions?
thank you.
Thank you.